Welcome to this EMCT-sponsored podcast on the topic of onboarding in emergency medicine, where we are recognizing groups and organizations that have raised the bar in improving an educational and training standard for those providers that are not residency trained in emergency medicine. It can be difficult as a private physician group to institute an onboarding program that is safe and effective for all the EDs that you staff. One of these groups we'd like to recognize today is the BlueWater Group. Our guest today is Dr. Guy Nuki, and let's join that discussion now because I think you're going to find it fascinating and inspiring. Well, welcome to this EMCT podcast on onboarding, an ongoing series that we have. Have a guest today, Dr. Guy Nuki from Maine. I'll let you do your introduction of your practice and all, but I want to thank you for attending today.
It's great to be here. I appreciate the invitation.
Great. So as you know, we've been doing a series of podcasts on onboarding, and you and I have had discussions, many times about standards of practice and how do we educate our EM providers to provide, the highest quality care for EM patients across the board, and with both of us having a rural component to our practice, and rural has many meetings. There are many types of rural facilities. Some are as busy per hour for the docs as they would be in a high volume academic setting, under and less resourced than those settings. And some are pretty sleepy EDs that it's either feast or famine, or sleep or terror. So those are the different types of rural facilities. But we've always talked about how do we prepare individuals to work in those environments. And so I've had a discussion with representatives from SEMPA and AAENP, and looking at what they've developed for standards, and having been on the ACEP Rural Task Force and Accreditation Task Force, and as chair for 2 years of ACEP's Rural Section, I've been involved in this topic and with discussions of how we can work to develop a standard. And ACEP has recommendations for oversight of APPs. There is this independent practice that happens at rural settings or under supervised practice, and no real onboarding standard. And so it's interesting that we've had this going on for decades, really, of this transition from the local family physician, seeing their community, working in the clinic, covering the ED. And now we have this new paradigm where we have those physicians really just doing their clinic work, commonly, maybe filling in the ED on occasion, but more and more we're seeing at very low volume what we call frontier rural emergency departments. Those volumes less than 4,000 or 5,000, and then extreme frontier less than 2,500 volume per year, being staffed more and more by PAs and NPs as sole providers. And then there is this volume, up to, 12, 15, 20,000. Really, emergency medicine trained physicians aren't really on board until you get to 15 to 20. But most of emergency medicine, the vast majority of emergency trained and boarded physicians are in those high volume facilities, more than 30, 40 or 1,000. And so that represents half of emergency departments in the country, roughly, that are covered by providers other than those that are emergency medicine trained. So we've been kind of going through the journey of groups like yours at BlueWater, as what kind of departments you cover, and how did you determine what providers to put at various facilities, and how do you assure that training of those providers. So how long has BlueWater been around, and how did it start? And did you start with just one hospital and a group of physicians and then expand, or what did you do?
Yeah. So it started back as a kind of a different iteration in 2009 in a community hospital in southern Maine. And it wasn't until late 2011, early 2012 that we kind of folded down the old company and created BlueWater, so that for the express purpose of really staffing rural emergency departments in Maine, because we had recognized there was, at the time, the care that was getting delivered was really not great for multiple reasons. Just the lack of experience management, as well as just struggling getting providers who had enough experience, or and this is a little sad to say, providers that had failed in multiple other places, and therefore they landed in these rural towns because it was the only place that would hang on to them, which I think thankfully we have seen mostly the end of. So that's very positive, because some of the stories from that era were pretty horrendous.
Yeah. No, I
So
know those as well.
yeah. So we currently have a number of different programs. We have 5 emergency departments. One is actually in East Boston. Another is a medium-sized community, but the other 3 are rural emergency departments, seeing anywhere from about 10 to 14, 15,000 patient volume, but they're still quite remote, just physically remote. I mean, one is 30 miles out to sea, and we're the only, the hospital is the only game in town. And so makes transport interesting. If it's storming out, that patient's yours for quite some time, because the only way anybody gets off the island is by helicopter.
Wow.
At least a patient. I mean, I get on and off the island by boat, but I don't need to have healthcare while I'm being transported. So we've recognized that getting the right staff there and making sure that they're providing good care is a key piece of what we do. And it's not just APP versus physician. For a number of years, we actually had a rule that you couldn't be a new grad from an emergency medicine residency to go work in one of these places, because the skill set was so different. Now, having said that, we have had I am proud to say, some phenomenal individuals who have really risen to the occasion. But most emergency medicine grads, residency grads, have never given thrombolytics to a STEMI without cardiology having a reason, standing at the bedside having a reason that would happen. Not a lot of management of OB or inpatient care, which when you're in a small place, for a small hospital to be paying to have an emergency medicine physician, an inpatient hospitalist, an OBGYN, and a surgeon, and is fairly cost prohibitive. And so I believe that emergency medicine is this, a great specialty to be able to supplant a lot of those things, because we really have the skill set to take care of the sickest patients, even if it's not that often.
Right.
And then, of course, there's our APP colleagues, and how do we get them up to speed? They have obviously much further to go. And then what their eventual skill set is obviously probably a big topic of conversation for you, the podcast.
Yeah. Well, and even at larger volume facilities, we wanted to hire PAs and NPs with experience. And where do they get that experience? So we started hiring, PAs right out of school and train them up. And at a high volume facility, you can do that. Now those facilities are even saturated. And so new grad PAs and NPs can't even gain experience at a high volume facility. So they're coming and knocking on rural hospital doors looking to get a job. And now it's put on that institution or that hospital. So it might be a health system, or it might be an individual rural or critical access hospital that now needs to determine what's the criteria for
Mhm.
that individual to work there. And if it isn't a responsible group that's running it, and it's the hospital itself, the current standard that we found in our rural task force doing a survey of hospitals using listservs from our APP colleagues and CALs and all, was that you had to have ACLS, ATLS, and PALs, which was the criteria for your family physicians that or family medicine residency trained physicians coming out, that they needed that skill set on the higher end, perhaps to take care of some ill patients. Not that that gives you all of the skills even to do that. That's just a merit badge. But that was just the criteria for them. And suddenly that's been adopted by these credentials committees for all providers. So now you can have a PA or NP license and then practice. But even our colleagues, and again, I say this with our PA and NP colleagues, they recognize, well, that's not sufficient. And they all know that. And that's why they are developing their standard of onboarding and minimum training to work in rural facilities as solo providers. But how do you work with that as a group like BlueWater? How do you decide, and what was that journey to for yourselves to determine that?
Yeah, that's it's really it's a I like the way you phrase the question because about journey. So I'll tell you about the first person that we hired, and we had signed a contract with a rural hospital, um, and then planned to staff it with physicians the entire time. Between signing the contract and starting work in the hospital, they hired a PA that they really liked, and we arrive all of a sudden. They say, well, by the way, here's a PA. She's fantastic. We really like her. We want you to hire her. And we said, well, it's not in our model, but as a good vendor or a good client, we said, okay, let's see if we can make this work. And it just so happens this person is extremely intelligent. She had been the lead PA for a number of years at a large academic facility, actually being the lead PA in the cardiac ICU. And her ability to manage sick patients in the cardiac ICU took care of, patients who were septic with endocarditis and things. And she had been doing this incredible care. And she came along and said, listen, here's where my areas of weakness is. I need help with pediatrics. I need help with orthopedics. I've been doing all of this reading. And she was just innately brilliant. And so we hired her, and she was fantastic. As a matter of fact, she taught me how to interrogate pacemakers. And for her, it was second nature. And so I tell that story because there are individuals who you just give them an opportunity, and all on their own, they're going to do fantastic. They're going to ask for help when they need it. They're going to learn really quickly. And we all know those people. The problem with that is you don't know who those people are.
Right.
And so I think the next step in this thought process is we will interview people. And when we interview someone who maybe has no experience, or they're maybe 1 year or 2 years, and they come and they say, you know what, Dr. Nuki, I got this. Like I used to be an ED nurse. I've seen it all. I was an ED nurse at a trauma center. I can be an ED provider. I've had 2 years of education. We don't hire those people. There's no teaching you can do to get that person to understand that we're all in a lifelong journey of learning. And if you think you can do this with the limited experience you've had, you don't understand what you're getting yourself into.
Right.
And so we wouldn't hire someone like that. However, we will hire, we would prefer, obviously, just like the large academic centers, we'd love to hire someone who comes along and says, I've been working for 5 years in emergency department. But we don't get a lot of those people. Some, So we do when there's nobody that we can hire and we need a spot filled, we'll hire someone who's a new grad, but we have a 1-year program for them that essentially has a number of components. First of which is they are an extra person on the schedule. They're there to learn for the first 3 to 6 months. And it depends on them. If they're like this person I talked about before, it's going to be closer to 3 months. If they are an average learner, it's going to be closer to 6 months. They do a little bit more than full time. They get paid a lot less. But the group also commits to bedside teaching for this person, recognizing that all of the physicians that are there want this person to be really good. I mean, it's in their own vested interest to do that. We also send them off to EM boot camp. Find it's a great drinking out of the fire hose experience for them.
Mm-hmm.
And they also get to meet a lot of other APPs that are doing emergency medicine. And then we have this online program that you're better at describing than I am, which we also think is a great supplement. And I'm not doing this to sell your program, Steve, but what I will say is that the folks that we see putting the hours and the work in up front are also the ones who, as we get to the end of this year, are really good APPs. They're the ones that are, and it may be the online program itself, but it also just may be the type of person that's going to put in that extra work. They're also the people that are staying late at the end of shifts, asking lots of really good questions, butting themselves into cases so that they can learn much more aggressively. And then, and on top of that, we do have some of our own lectures that we give them. And they, we have them spend some time with our hospitalist physicians and various other parts of the hospital. And we find at the end of that year, many of them, the vast majority of them, are really ready to be an APP in one of our emergency departments.
And they're still working alongside another physician.
So our staffing model. So, back to trying to recruit people to work in rural areas, recruiting good physicians who are able to, float a pacemaker, do a lateral canthotomy, manage a trauma patient on their own, and want to do that in a rural setting is a challenge. And so one of the ways we do that is in most of our rural hospitals, we have 24-hour shifts, but at night, there's an APP that's there. And so we do have some daytime APP shifts in some of our busier emergency departments, but all of them have a nighttime APP shift, which allows the physician when things are slow and there's so the physician can go lay down until they're needed, basically. And then we have some guardrails about when they do have to get up and see patients and be involved. And so the APPs then are really the ones that are determining sick from not sick. And that's the critical piece that they really need to learn. And then how to manage those lower acuity patients on their own. And then quite frankly, having a second set of hands when you're taking care of a really sick patient at night is a godsend.
Yeah. No, even at a high volume facility that I was at, we would see 65, close to 70,000 patients a year in a busy year. And we still had one doc going home at 5 a.m, which means they stopped picking up patients between 3 and 4. And it was just the doc and a PA that was there until the next doc would come in at 7. So there were a couple hours where clearly just those two providers, and it can be busy in the middle of the night and you can have multiple traumas. And the other, physician at 5 may have gone home a little early or maybe hang around to help in case you have that crisis. But, timing is everything. And periodically, our APPs that would work nights needed to step up and for a short time, there might be multiple traumas and you may be doing procedures and intubations. And so we indulge the interest of our APPs that are what you're talking about, those that are really motivated and wanting to practice in the full scope, potentially, of emergency medicine. and that's how they learn to get their legs under them and be able to then branch out and go into some rural solo practice where there aren't any other providers, and really they are probably more suited and best fit for that over many of the current providers that would be going to those facilities, and because we had done essentially a 12-year residency for some of these providers that just felt at that time, hey, I think I'm ready to go. And they've done a terrific job, and still, working at the high volume facility, but working part-time rural. It was really ideal. Now that they didn't have to wait that long, but they knew what they didn't know.
Yep.
Just because they've been in that environment, they've been the decision maker, they've been humbled many times, and they're scared. But they get, lured into like, dip a toe in it, and then they have some successful shifts. It's those you're talking about that are so bold and go, no, I got this. I've been doing this. I can go out and do it as a provider, that just jump right into it without being adequately prepared, that, I'm the shoulder to cry on when, something really tragic goes, and that has happened. And then they're back working, unfortunately, in a different department, and again under supervision, because now they've been burned, they've gotten burnt out in emergency medicine because of a tragic outcome. And that's bad for the patient. It's bad for the system, because now you've got an onboard a new individual. It's financially expensive. It's medical legal risk. It's again, it's unfair to the patient. And it's really not the fault of that provider for making that decision. It's the fault of the system for allowing that to happen, in my opinion. And again, that comes down to credentials committees that aren't given adequate guidance by national organizations. So there isn't anyone that's really stepped up, and, even by SEMPA or AAENP, certainly not by ACEP, to say these are the criteria, except for ACEP wants an emergency physician in every department. And to their credit, they came with new guidelines just this year on recognizing that there are situations where PAs and NPs are working independently. I think it's still a bit of a stretch to think that even by telemedicine, they're going to talk contemporaneously about every single patient. I think that's asking for a higher standard than even exists at high volume facilities, because we all know that PAs and NPs discharge patients at high volume facilities based on their clinical judgment of it being a lower acuity. Now, they aren't discharging, or managing an entirely level 1 or 2, triage acuities, and making all their dispositions. They're involving the emergency physician in those cases, but there are many cases that they're discharging that are low acuity and clearly have a good plan in place, and they're slowly given more and more autonomy even in those settings. I mean, that's how they even prepare to go and practice solo and gain that confidence.
Yeah, I agree. I think what we do is we create guardrails. These are patients that require the physician at the bedside. And some of them are obvious. I mean, if you're going to have thrombolytics, you got to have, the interesting thing is, we've learned over time. So for instance, one of the rules was, the physician has to be at bedside for the patient getting thrombolytics. Well, it's really the consideration of thrombolytics at the physician that we want the physician at the bedside for. So now it's any patient that might be a candidate for thrombolytics, and so over time you become, as you do this, it becomes, I guess, complex is one way to put it, but the other way is it's more sophisticated model about how you work with APPs. And the other piece of that is also recognizing that they are individuals with careers and aspirations, and they want to learn, they want to be able to do more, but you also want the people that also don't want to be in a bad position on their own, because the moment you hire someone that doesn't care about that is when you have a problem. So, if I'm working in the middle of the night and patient comes in and needs to be intubated, if it's someone whose SATs are at 100% and they're easy to bag and they're not a child and things like that, I'm absolutely going to stand at the head of the bed while the PA that I'm working with goes ahead and has first attempt at that airway.
Right.
It makes their job much more enjoyable for them. It gives them more skills. And so then when the next night, when it's a really, what I used to call a Humpty Dumpty airway, where you're like, oh my gosh, I don't know if I'm gonna be able to do this. The PA that I'm working with knows exactly what I'm looking, what to look for, exactly what I'm trying to do, and has actually done it a number of times themselves, and more than just a number, but quite a few. And we do have, there's some other training courses such as CALS, and we have a sheep lab and things. But, I want the more skilled person to be the one that's helping me, because there's nobody else.
Right. Right. Have you ever had a hospital that you decide to contract for emergency coverage ask what your onboarding is, or ask what what the quality of your providers are going to be? Do they?
So that's really interesting. When you talk to the senior leadership, they typically, very often, especially in these small rural hospitals, we will show them the data about how we're doing at other hospitals. And they look shocked, like, how do you even know this? I'm like, you don't measure this in your own hospital? No, we have no idea how to do it. I don't think that that's a common, when you get into larger hospitals, they in general have pretty strong quality departments that have all sorts of data. But for some of the smaller hospitals where they have limited resources, oftentimes they don't have any. But they're interested in how we're doing, but they're really looking at those metrics. That when you look at quality metrics, sometimes it's very difficult to tease out really the quality of care that's being provided. Not to say the metrics aren't important, they are. It's what I spend a lot of my time doing. We review all of our intubations, and there's how many took more than one attempt? How well was it documented that they were pre-oxygenated? All of those sorts of things. All of those are important, but we know that it's very hard to then measure, well, geez, you could put inexperienced providers into an ED that would still end up looking like the quality metrics were okay, but the care wouldn't be great. So the senior leadership just asks about the metrics, and they don't seem to care about the other stuff. Now, there are some credentials committees that do care, and they ask ask some of those questions. But in general, we're the ones that show up to these small hospitals and say, hey, this is how we do things, and this is how we, work with APPs, and this is how we make sure our docs are doing a good job. And what we're finding is other departments are then saying, oh, wow, like maybe we should be doing that too. So I think that other specialties that have APPs doing lots of their work. I mean, look at primary care. We've worked in communities that have no physician primary care. Their entire primary care is being done by APPs.
Right.
And so, when you then start to say, listen, we've got to really look at how people are performing, and quality metrics are important, but also actually seeing how they're performing is really important, and making sure you're onboarding them and understanding what their level of practice is, I think, really critically important.
Yeah. The ASAP Rural Task Force came out with recommendations for onboarding that included foundational training. It included airway. It included team-based learning and skills labs, that sort of thing. Time in a high volume facility, and then tele-emergency medicine support, which could be substituted certainly for having the physician on site, as you guys have. And it sounds like you're really checking the boxes on all of that. And another facility of best practice we recognized was the Mayo system that was doing that as well. And we'll be talking with them in another podcast on their journey through this and trying to figure this out. But wouldn't it be nice if the credentials committees could say, these are the groups that we're going to allow to staff, or if you've got this established onboarding, this is who we'll allow. Or in lesser volume facilities in the Midwest, unlike the East Coast, I mean, a rural hospital might have 40,000 visits and be out in a, remotely in a rural area, but still be considered pretty moderate volume by Midwestern standards, or even high volume. We're talking facilities that see less than 500 patients a year, sometimes less than 1,500 patients is certainly not uncommon through the Dakotas and Wyoming and that sort of thing. But really anything less than 2,500, we're calling extreme frontier. And those are almost exclusively staffed by PAs and NPs. And sometimes that's the first job that they're able to get. And unfortunately, these hospitals are very squeezed financially and just say outright, look, we can't afford to send our PA or NP to a higher volume facility, even within their health system, even if they've got a hub and spoke model. They aren't sending their APPs to the higher volume facility to get them trained up per these rural task force recommendations. They're sending them right out to the rural hospital, and they might have them work with another APP for a few shifts, maybe a month, maybe 3 months, but that's it. They that what kind of training is that? And unfortunately, that standard doesn't exist. Now, SEMPA and AAEMP are looking to create that, but again, that's been a slow process, and they have some criteria in place. Not every NP or PA is a member of SEMPA or AAEMP. I think they should be, and support those organizations that are looking to improve the quality of care. But it would be nice if a national organization, and I've pushed ACEP on this as well, and I think ACEP has really stepped up. And it becomes very politically charged because the old guard in ACEP remembers the days of not having emergency physicians, and you and I, kind of caught the tail end of that as we came into this career, and that battle that they felt that they were fighting to have emergency physicians there. But before we talked today, I was thinking of it. I was a ship doctor going to Antarctica, and this is probably a poor analogy, but discoverers of Antarctica wanted to claim Antarctica, and the English and and the Argentinians going, hey, wait a minute, we're right there, we want it. And then later, countries are saying, yeah, but if you're not going to have a stake there and live there, how can you claim this territory? So it became a battle. So can we, as emergency physicians, claim all emergency departments if we aren't actually going to occupy them with bodies? Or in the meantime, is there a way that we can have medical directorship and oversight and telemedicine and still play a role? And it's interesting, we're seeing the evolution of that, I think. But to claim ownership of something that you're not going to actually staff just seems like a bit of a stretch. And I'm saying this obviously as emergency medicine trained, and I have a lot at stake. But at the same time, I recognize I spend half my practice rural, and sometimes at some of these very low volume hospitals, at a 3,000 volume hospital, I trained my replacement, but I didn't really train my replacement. I was there because the Mayo system recognized that they needed skilled providers. There was no intent to have an emergency medicine physician there forever. The idea was to have a PA or NP work at this low volume facility, and we were the bridge. And my hat's off to them for recognizing that we aren't going to make it unsafe for patients. We're going to bridge that with skilled providers, and our emergency physicians will fill in until we can train up the right individual. And so that individual, worked with me for some shifts and did the EMCT program and did other things, but got skilled up and went to the OR at Mayo and learned intubations and now she's working there independently. Did I feel like I lost my job to her? No, I went in and filled in on some shifts. And frankly, that isn't my desire to work at that facility on a regular basis. So I think we just need to shift the mindset that somehow, PAs, NPs, even family medicine physicians are stealing our jobs. I think we need to collaborate and staff all these facilities and provide a level of care that is a standard, because a standard just doesn't exist.
Well, I mean, I think that goes back to the adage, healthcare or emergency medicine for us is not there to provide us with a job. Healthcare and emergency medicine is there to take care of patients. And so I think we as certainly as a company, but I think ACEP, I think healthcare organizations really need to think, okay, well, wait a minute. What may be best for me is not what's right for the community or for the patients. And we really need to think about how do we best provide that care to the patients and to those communities. And we need to do it in a fiscally responsible way, certainly. I mean, the way we staff, we feel that there are always going to be some patients who need the skill level of having an emergency medicine physician's hands on the patient. And, if you get to a low enough volume, that might only be once or twice a year. And you at some point need to say, well, it's not a service that our hospital provides. Several of the hospitals we work do not have OB programs.
Right.
So if somebody shows up and needs an obstetrician for an emergency C-section, it's not a service the hospital provides. And they'll be, and we just need to feel comfortable with, okay, in order for the hospital to exist financially, we can't service that patient appropriately. The outcome is not going to be as good as we would like. That's just the reality of the healthcare system where we have limited resources. Having said that, I do think that, as you were talking about at the beginning, we worrying about losing our jobs as opposed to, wait a minute, we are going to take ownership of this. We will be there. We are going to help. And it may be, that means you get in the car and drive out there and spend some time. But I also think one of the first things that I would love to see emergency medicine as a organization focus on is recognizing this is a different specialty a little bit. There's some not so subtle different skill sets, and getting emergency physicians prepared to work with that skill set in rural areas, which also means working with APPs differently, feeling comfortable teaching APPs. Not all physicians are going to feel that way, but you're going to have to feel comfortable managing a vented patient without a respiratory therapist at night.
Right. Oh,
Right?
The first time I had to put a chest tube in and then hitch up the Plurivac, they're like, huh? Wait,
yeah, exactly.
I got to plug in this hose and figure out suction and fill the chambers. What?
Yep.
I got to what? But and again, at a facility that I work at, I'm doing inpatient care, entirely foreign. I mean, that was not part of our practice. We certainly did some of that in internal medicine when we trained, and we had some offsite rotations. We get the concept, but that is not something that right out of residency I'd have been prepared to do. And certainly OB is always something that frightened me, and I didn't go into that for a reason. I mean, I think I had enough deliveries and cases to know that I'm dangerous if I were to practice it. I've had the opportunity to catch a few deliveries. Fortunately, never had a shoulder dystocia or a breech that I've had to deliver. They've come delivered, fortunately. So no, I haven't had that eventuality. And any time that I've had emergency C-section, I've had an OB there. And I love those rural hospitals where I have it. I have worked at them that I don't, and just knock on wood that I just haven't had to deal with it. It's horrible to think. I mean, but we've all had situations that we couldn't manage what was wrong with that patient in a rural setting. We sent them in a helicopter and they died en route, and now it's too late to operate on them for their internal or injuries that had they been at the trauma within 5 minutes of the hospital, they probably would have survived. But unfortunately, just given the nature of rural emergency medicine, that just isn't the case. But yeah, it's an entirely different skill set. But are we going to get our emergency medicine residents to do another year to learn inpatient medicine, to learn enough OB to be skilled in those facilities? Or is it our family medicine physicians that may have had more OB experience that are going to get trained up in the higher end critical care that are going to do some of these more remote and more difficult to staff rural facilities?
Well, I mean, I would love to, as an emergency medicine physician, I'd love to see emergency medicine be the ones that take over Antarctica. I mean, I think that using your analogy. So, and I think we can do it. And, I don't necessarily think you need to add another year. We actually work with a residency that had developed a fellowship year for rural emergency medicine, and it was a great experience working with that. We actually just now finished that year, and the person had a phenomenal experience and is now working out west in a rural ED and feeling much more comfortable about doing that after spending a year with us. I think that, family medicine has a model for training rural physicians. They have a rural track. There's lots of ways to train people. And it may be developing rural tracks within emergency medicine residencies, or at least giving people true rural experiences. I remember talking to a residency director from, we'll just say, a large inner city emergency department, and they said, yeah, we have our residents go and spend, we call it the rural month or the community month. It's at a 65,000 visit ED that was half an hour from the big city, and had, they weren't so they're not a trauma hospital. Like, okay, but they do everything else.
Yeah.
They actually, they've got a cath lab. They've got all these
radiology.
Yeah, exactly. So I'm like, that is a very different experience. So, and I think, though, going back to, I think your question at the beginning about how the role of APPs in these settings, I think that the role of the physician when you're in a lower volume setting is to oversee people, and to help APPs be able to grow into providing that care. So, I talked about the primary care, the town where the primary care group was all APPs. The role of a family physician, if they had been able to hire an internist or family physician, in that, would have mostly been to really make sure those APPs were doing a great job in that primary care. But if all they did was their own primary practice and allowed the APPs just to continue to provide the access to the rest of the community, that wouldn't have worked either. So I think we have to get used to what those different roles are. And, once again, I think emergency medicine should be playing this role, but they're not going to do it I don't think it's going to work just by force.
No.
Right. Yeah. So.
And these guidelines are great and constructive and show a step forward. But I can tell you, talking with major health systems, they don't see any real guidance. There isn't any standard for onboarding and for education. And so they've taken over a lot of these smaller hospitals. And so they let the smaller hospitals just keep up with whatever their current standard was for onboarding and credentialing, and ACLS, ATLS, and PALS, check the boxes, and then you can start working, and then you figure it out, and they give them a CME allowance and then let them go. And I think a lot of health systems recognize clearly that that's not adequate. And so they're trying to invent the wheel themselves. And many physician groups, contract management groups, larger health systems are doing that. And so we put groups that do it right, and we recognize Mayo, and certainly BlueWater is doing that as well. And that's why I wanted to kind of profile your group as, as a model, that if someone really wanted to reach out and say, okay, how can we make this work at our facility? What is, safe care? Because otherwise you just wait for a disaster to happen. You put someone there, and it isn't until something happens or you get enough complaints from the receiving hospital, because they're usually it, in the hub and spoke model. They start complaining about patients being sent in inappropriately or too late or talking too late or being misrepresented. That complaints come up, but that only lasts so long, and those index cases kind of get forgotten when you start looking at the daunting task of actually having to develop a comprehensive onboarding process. And then all discussion falls apart. And so then you piecemeal a little bit of the rural task force recommendations. And I've gotten some health systems to do that. And we alluded to MCT, all right, but we were recognized as a high quality foundational program. So the first step in those. And so, but that alone, I'm not saying that you're prepared. Go through EMCT. You're not prepared to be an emergency provider any more than you are by going through ACLS, ATLS, or CALS alone, or PALS. None of those are going to make you a provider. It's really a comprehensive program. It really is a lot of steps. And then you need to have guardrails and have telemedicine support. We'll be talking with Avel coming up as well, a representative from them, one of the major telehealth providers in EM, about their experience and the need and how they ended up providing that. So all of this has been kind of piecemeal together. And it's just interesting. I mean, we're in the middle of the evolution of this, but working through this process, when some of us can see the end point where it needs to be, it's just a struggle just watching facilities or people struggle with this question. The answer should be pretty simple, but in time we'll figure it out and have a standard. So,
well, I mean, wouldn't it be great if ACEP or we'll just say all the major players in this were able to come together and recognize that it's not about their own personal interest, but it's about providing care to the communities and the patients in rural areas, and come up with some practical guidelines around what it takes to become an emergency medicine nurse practitioner, an emergency medicine PA, and say, look, you know what, we all feel that these things are doable, they're achievable, and they will allow you to work at a certain level. And if it's up to me, I would love to see it be specific to rural areas. Or maybe you have one that's specific to rural and one that's specific to working in an urban. I mean, our urban EDs, we also have APPs, but their role is very different.
Yeah.
In those EDs. So, and they're different skill sets. So, creating what it means, creating some guidelines that everybody can agree to.
Yeah.
I think it would mean compromise, which is sometimes challenging. But, once again, it's, when you go to the meeting at the hospital and people are arguing about how to create a system, and someone raises their hand and says, why don't we put the patient in the center of the table and figure out what the system is that's best for the patient? And then that person hopefully is in a position of power to be able to force everyone to stick to that focus. You usually end up with the best system.
Right. Well, when ACEP was asked to create conditions of participation for conversion to rural emergency hospitals from critical access hospitals, they actually partnered with American Academy of Family Practice to come up with a statement as to, what should supervision be and who should be working in these rural emergency departments. But that turned out to be a different standard than for critical access hospitals. So who is going to convert to a real emergency department if the conditions of participation are much more rigid than just staying a critical access hospital. So it became a bit politically charged, but at least it opened the dialogue between the organizations. And I think there is an opportunity to really open it between all the organizations. And there have been APP task force. There's been a lot of discussion, but it gets politically charged and it becomes a daunting task, and you get stuck in convictions that are pretty fixed, and then it's inaction in the end, and not entirely, but it just doesn't get the action it deserves. And the rural task force is one of those, and I keep beating that drum with ACEP, hoping that that we could get recommendations adopted. And the recommendations are out there, but not widely and not widely known. And I would like to see health systems look at that and say, you know what, we do need a minimum standard of onboarding, and then look to groups that have done it right.
I'm if there's anybody out there that's watching or listening to your podcast that wants to do this for their own communities, I am you, and I'm sure there's a number of other people that we'd all be happy to say, hey, listen, this is our experience, this is how we can help. I don't think that it's until the political situation allows us to kind of create those national standards, which would be ideal. It'd be great. And I know that ACEP is always working on trying to do this work, and so I think we'll get there.
We will, and moving the needle, and it changes with each leader. I worked closely with Dr. Schmitz while I was under ACEP, and I think we moved the needle a long way from where we were, and just couldn't quite move across the finish line. But again, it's progress. We're seeing the evolution of this, and we'll see a standard develop and see criteria that are necessary for safer patient care. So anyway, but great. Well, really appreciate connecting today and being able to talk about this important issue and kind of profile BlueWater as a group that's gone through the journey and really recognize the issue and is doing it right.
Well, as usual, it's always great to talk to you, Steve. I appreciate the opportunity.